Number 41, a blood sample from a patient with a high titer cold agglutinin analyzed at room temperature with an electronic particle counter would cause an error in the blank. Is it letter A, hemoglobin and MCV, letter B, MCHC and WBC, letter C, WBC and RBC, or letter D, MCV and MCHC? Take note po, high titer cold agglutinin. Correct answer po is letter D po, MCV and MCHC. So these are usually the causes of some errors in the automated machines. We have, for example, high patient glucose concentrations. Again, high patient glucose concentrations of more than 400 mg per dl may result in intracellular hyperosmolality in RBCs. So it may cause a high MCV and hematocrit but with a low MCHC. On the other hand, cold agglutinins in high titer give a falsely high MCV, low RBC counts, and a very high MCHCs. So a good clue for this problem, for this cold agglutinin, is to look for RBC clumping in the thin area on the blood smear. Also, to resolve the problem, we warm the blood or diluent to 37 degrees Celsius, okay, to eliminate. Now, other than high patient glucose concentrations and cold agglutinins, very high plasma lipid levels also contribute to errors. Now, very high plasma lipid levels resulting in lipemic plasma may produce turbidity in the WBC aperture bath, and this may falsely increase the hemoglobin, the MCH, and the MCHC. For number 42, in essential thrombocythemia, the platelets are blank. Again, in essential thrombocythemia, the platelets are, is it letter A, increased in number and functionally abnormal, letter B, normal in number and functionally abnormal, letter C, decreased in number and functionally normal, or letter D, decreased in number and functionally abnormal? For number 42, okay, of course, the answer is letter A, increased in number and functionally abnormal. So I have here the list of myeloproliferative neoplasms. So this includes, for example, polycythemia vera. Now in polycythemia vera, remember, RBCs are increased, granulocytes are increased, and platelets also in the peripheral blood. So normal or decreased erythropoietin levels for PV, and this is also associated with JAK2 V617F mutation. Again, for CBC, increased hemoglobin and hematocrit, normal RBC morphology, and increased WBCs and platelets. For lab testing, decreased EPO levels, increased RBC mass, and normal to increased LAP. For essential thrombocythemia, again, for essential thrombocythemia, this is characterized by increased platelets and megakaryopoiesis, where the platelets may not function normally. So for the CBC, platelet counts are of elevation, so greater than 450 times 10 raised to the 9 per liter po. And platelets may be of variable size and sustained granularity. So sa bone marrow, okay, features megakaryopoiesis with increases in erythropoiesis or granulopoiesis. Okay, so megakaryocytes may be larger than normal. This is also associated with JAK2 V617F mutation. And symptoms for essential thrombocythemia include bleeding, clotting, neurologic symptoms, and even. Now, for essential thrombocythemia, remember, these are symptoms related to clotting and bleeding. CBC, increased platelet counts. Again, that's greater than 450 times 10 raised to the 9 per liter with sustained elevations, where the platelets may be of variable size and granularity. Again, bone marrow features megakaryopoiesis. I'm sorry, that's without increased. Again, megakaryopoiesis without increased erythropoiesis or granulopoiesis. And megakaryocytes may be larger than normal. Now, according to the first criterion, which is the 2001 World Health Organization criterion for the diagnosis of essential thrombocythemia, platelet count should be greater than or equal to 600 times 10 raised to the 9 per liter. In 2008, this was revised. Also under the World Health Organization criterion, diagnosis of essential thrombocythemia, this was revised, of course, a platelet count of greater than or equal to 450 times 10 raised to the 9 per liter. And also we have primary myelofibrosis. Now, primary myelofibrosis. This is chronic myelofibrosis, myelofibrosis with myeloid metaplasia. Now, symptoms of primary myelofibrosis. This includes fatigue, weakness, shortness of breath, in addition to splenomegaly. Now, CBC, that's normal to decreased hemoglobin and hematocrit with RBC and platelet abnormalities. This is also associated with circulating micro-megakaryocytes. So, in the bone marrow, there are areas of fibrosis with hypercellularity of granulocytes and megakaryocytes. And this is also associated with JAK2 mutation. For number 43, in storage pool disease, platelets are primarily deficient in what? Again, platelets are primarily deficient in, is it letter A, ADP, letter B, platelet factor 3, letter C, thrombostenine, or letter D, thromboxane A2? Again, storage pool disease are primarily deficient in letter A, ADP. So we have the alpha granule deficiencies, remember. These are platelet function abnormalities in which both aggregation and release properties are diminished. So storage pool disease, also known as gray platelet syndrome, this is a congenital platelet disease which associates thrombocytopenia and aggregation abnormalities. So inheritance with storage pool disease is usually autosomal dominant. And this disorder is typically mild, with patients commonly presenting with mild epistaxis, bruising, or long-lasting hemorrhages after accidental cuts. Again, storage pool disease or gray platelet syndrome is characterized by marked decrease or absence of platelet alpha granules and, of course, specific alpha granule proteins. So morphologically, platelets appear large and they contain few granules, giving them a gray appearance with the right gem-sustained blood smear. So for the diagnosis of this storage pool disease, this is typically laboratory diagnosis typically reveals a decreased platelet count, low MPV, and abnormal aggregation. For number 44, a citrated blood specimen for coagulation studies is to be collected from a polycythemic patient. The anticoagulant should be, letter A, the standard volume, letter B, reduced in volume, letter C, changed to EDTA, or letter D, changed to oxalate. Take note, that's polycythemic patient. Correct answer is letter B, reduced in volume. So I have here the summary of differential effects of testing different sample types on select hemostasis tests. So this is from ASCP, from the ASCP journal in lab medicine. So we have sample types and their potential consequences on some factor assays. So for example, EDTA plasma. EDTA plasma might influence fibrinogen and D-dimer D-dimer assays. So EDTA plasma can falsely lower levels of factors 5 and factors 8. The same goes with serum or fully clotted coagulation sample. This also falsely lowers factor 2, 5, and 8 levels, but it falsely increases factor 7 levels. Another thing, for heparin contamination, sa baba, heparin contamination is either ex vivo or due to collection tube error. So remember, heparin contamination prolongs the PT, APTT, and thrombin time. So usually in here, thrombin time is raised. Thrombin time is greater than the APTT. Also, APTT is greater than the thromboplastin. The prothrombin time. So remember, heparin contamination falsely lowers fibrinogens. Also, we have the summary of effects of inappropriate sample processing issues on select hemostasis tests. So, for example, whole blood refrigerated prior to centrifugation, this may lead to platelet activation and loss of factor 8 and von Willebrand factor. Hence, this may lead to false diagnosis of hemophilia or von Willebrand disease. Now, filtered plasma. This may induce loss of fibrinogen, factor 8, and von Willebrand factor. So this may lead to false diagnosis of dysfibrinogenemia, also hypofibrinogenemia, hemophilia. At the same time, it prolongs the coagulation test times. And of course, pag delayed, transport, delayed testing po, or poor yung storage, this may induce loss of labile factors, especially, of course, factors 5 and 8. And we also have here the summary of a misdiagnosis or misidentification in hemostasis. So, for example, false positive lupus anticoagulant may arise from testing po of the following samples. So, for example, in vitamin K deficient patient, for false diagnosis of von Willebrand's disease, this can arise from testing filtered normal plasma, normal serum, and normal plasma derived from refrigerated whole blood sample. And we have false diagnosis of hemophilia A also. False identification of factor inhibitors. Usually, this can arise from heparinized normal sample, also in the presence of course, lupus anticoagulant. Okay, refer to the following results. PT is prolonged, APTT is prolonged, and the platelet count is decreased. Is it letter A, factor 7 deficiency, letter B, von Willebrand's disease, letter C, disseminated intravascular coagulation, or letter D, factor 9 deficiency? Take note, platelet count is decreased. This is characteristic of, correct answer is letter C, DIC. So remember, in fibrinolysis, primary fibrinolysis, normal po yung platelet count. But in secondary fibrinolysis, decreased na po ang platelet count. Now, normal RBC morphology for primary fibrinolysis, but secondary fibrinolysis is characterized by RBC fragments po, or schistocytes. Both primary and secondary fibrinolysis have abnormal TT and APTT levels, but of course, characteristic of secondary fibrinolysis is yung positive D-dimer po. Next, which of the following abnormalities is consistent with the presence of lupus anticoagulant? Again, which of the following abnormalities is consistent with the presence of lupus anticoagulant? Is it letter A, decreased APTT, bleeding complications? Letter B, prolonged APTT, thrombosis? Letter C, prolonged APTT, thrombocytosis? Letter D, thrombocytosis and thrombosis? Correct answer is letter B, prolonged APTT and thrombosis. So just in case nakalimutan po ninyo, again, lupus anticoagulants, these are autoantibodies produced by the immune system that mistakenly attacks certain components of the body's own cells. So they specifically target phospholipids as well as the proteins associated with phospholipids. Now remember, the presence of lupus anticoagulant in the human body is associated with an increased risk of developing inappropriate blood clots or thrombosis. And these clots, by the way, may block blood flow, leading to stroke, heart attack, or pulmonary embolism. Now, LAs inhibit the chemical reactions that lead to clotting in the PTT. So, initial testing, again, of lupus anticoagulant typically involves one or more tests. We have the partial thromboplastin time, the LA-sensitive, partial thromboplastin time, and lastly, the dilute Russell-Viper venum test. So remember, all of these tests measure the time it takes in seconds for a plasma sample to clot, because lupus anticoagulant is said to prolong the time. Now let's go to the 4 criteria for the diagnosis of lupus anticoagulant according to the International Society of Hemostasis and Thrombosis. So first criterion, we have a prolongation of one or more of the phospholipid-dependent clotting tests. Again, that includes APTT and the dilute Russell-Viper venum test. Second, the presence po of an inhibitor confirmed by mixing studies, which is usually not corrected. And we have number 3, evidence that the inhibitor po is directed against phospholipids by neutralizing the antibodies with a high concentration of platelets, okay, in the platelet neutralization test, and also lack of any other causes for thrombosis. So lupus inhibitor is not commonly time or temperature dependent. Next, we have the heparin clotting time may be used to monitor. Again, heparin clotting time may be used to monitor A, heparin therapy, letter B, warfarin therapy, letter C, fibrinolytic therapy, letter D, hirudin therapy. Okay, correct answer for heparin clotting time, we have letter D, hirudin therapy. So we have the heparin clotting time. This is a snake venom-based clotting assay that may be used to monitor hirudin therapy in instances po pag yung baseline APTT po ay prolonged. Maybe due to lupus anticoagulant or factor deficiencies. Now, APTT po is insensitive to hirudin levels above 0.6 mg per liter po. And this may result in a And this, insensitivity may result in a drug overdose po. So remember, just a summary, eccarine clotting time is used to monitor hirudin therapy. APTT is used to monitor heparin therapy. We have the INR, or the International Normalized Ratio. This is used to monitor warfarin therapy. And we have the D-dimer is used to monitor fibrinolytic therapy. And we have the anti-factor 10A heparin assay to monitor low molecular weight heparin therapy. For number 48, which of the following is the preferred method to monitor heparin therapy at the point of care during cardiac surgery? Pa-highlight naman po ng heparin therapy at the point of care. Is it letter A, APTT, letter B, activated clotting time test, letter C, PT, letter D, thrombin time? Okay, correct answer po is letter B, activated clotting time test. Now remember, normal ACT po is, it can range from 98 to 100 seconds. For those patients undergoing heparin therapy, as a result of deep vein thrombosis po, yung ACT nila can range from 80 to 240 seconds. Relatively mas mataas. Of course, mas mataas talaga sa cardiopulmonary bypass po. For cardiopulmonary bypass, patients undergoing cardiopulmonary bypass po, 400 seconds po yung ACT. Next, a patient is taking 10 mg per day of Coumadin or warfarin. Now, the results of which of the following lab tests will be most impacted? Is it letter A, protein C level, letter B, antithrombin 3 level, letter C, factor 5 Leiden mutation, or letter D, factor 8 level? Of course, anong answer po natin? We have letter A, protein C level po. Now, remember, oral anticoagulants like Coumadin and vitamin K antagonists, they inhibit factors 2, 7, 9, and 10. So, to include protein C and S, which are also vitamin K dependent. So this Coumadin or warfarin po, again, crosses the placenta and is not present in human milk. This is not recommended for pregnant and lactating women. So warfarin is a vitamin K antagonist, vitamin K antagonist drug that retards synthesis of the active form of the vitamin K dependent factors. Again, we have the 2, 7, 9, and 10. Antithrombin is a heparin, by the way, not a warfarin cofactor. And we have the International Normalized Ratio, which is, or the INR, which is used to monitor warfarin dosage. Next, for number 50, what blood type is not possible for an offspring of an AO and BO mating? Is it letter A, AB, letter B, A or B, letter C, O, or letter D? All are possible. As you can see sa Punnett square, okay, all are possible po. So, pwedeng AB, BO, AO, and O po. Okay, so all are possible po yung answer. For number 50, we have letter D. Next, for number 51, which of the following is the most helpful to confirm a weak ABO subgroup? Again, pa-highlight po ng weak ABO subgroup. Is it letter A, adsorption and elution? Letter B, neutralization. Letter C, testing with A1 lectin. Letter D, use of antiglobulin reagent. Correct answer po is letter A, adsorption again, and elution. So remember po, if the red cells show a positive DAT, then the IgG antibody po has coated incompatible antigen-positive red cells po. And if the screening cells and panel cells po ay nagpapakita ng missing or weak reactions po, most of the antibody is on the red cells, and this would need to be eluted before it can be detected po. So this elution procedure is followed po by a panel performed on the eluate that would help to identify the antibody. So antibodies causing a positive DAT would be coating red cells, and they would require an elution, not an adsorption, to identify them. For number 52, what is the most likely cause of the following ABO discrepancy? Okay, so kung mapapansin po ninyo, it did not react both sa forward and reverse typing po. Okay, so kung ganito, that means, kung mapapansin nyo, sa reverse typing po, okay, walang reaction, and sa forward typing, so that means may missing or weak antigens. Tama po ba? Now, pag missing or weak yung antigens, like sinabi ko last time, we have to consider the patient's history. Tama? Kung, or yung patient's age. So, sa tingin nyo, anong answer dito? Is it letter A, recent transfusion with group O blood? Letter B, antigen depression due to leukemia? Letter C, false negative cell typing due to RULU? or letter D, obtained from a heel stick of a 2-month-old baby po. So, ang answer natin, of course, that's letter D. Again, obtained from a heel stick of a 2-month-old baby. Again, this is under Group 1 ABO discrepancy po, characterized by missing or weak antigens. Next, for number, okay, number 55 or 53, a stem cell transplant patient was retyped when she was transferred from another hospital. What is the most likely cause of the following results? Again, stem cell transplant patient po. Highlight naman po ng stem cell transplant patient. Kung mapapansin po ninyo, it reacted po sa forward typing. Strongly reacted with anti-V. Tama sa forward typing po. But, okay, wala pa ring reaction. Again, wala pa rin pong reaction sa reverse typing. Again, missing or weak antigens pa rin to. Okay, so ano yung kailangan natin i-consider? Aside sa patient history po, okay, this may be due to tama ba? Immunodeficiency states po. For number 53, we have letter C po. Again, 53, letter C. When unexpected reactions occur in the forward and reverse grouping, may be caused po ito again by problems with the patient's serum as seen in the reverse grouping, or problems with the patient's red cells as seen in the forward grouping, or problems with both the serum and cells. Now, all ABO discrepancies must be resolved prior to reporting a patient or donor ABO group. So let's discuss Group 1 ABO discrepancies. Now, Group 1 discrepancies are associated with unexpected reactions sa reverse grouping po, due to weakly reacting or missing antibodies. Again, kapag ang reaction in the reverse grouping is weak or missing, a Group 1 discrepancy should be suspected because normally, RBC and reverse grouping reactions are very strong. Isang reason po kung bakit may missing or weak isoagglutinins ay dahil yung patient ay may depressed antibody production, or in other words, di siya nakaka-produce ng ABO antibodies. Now, common populations with discrepancies in this group include newborns. Remember, the production of ABO antibodies is not detectable until 4 to 6 months of age. Also, for elderly patients, where the production of ABO antibodies is depressed, and also patients with leukemia. Example, chronic lymphocytic leukemia or lymphoma, demonstrating hypogammaglobulinemia. And we also have for patients using immunosuppressive drugs that yield hypogammaglobulinemia. Patients with congenital diseases or acquired agammaglobulinemia. We've also patients with bone marrow or stem cell transplantations. Usually, patients develop this hypogammaglobulinemia from therapy, and they start producing a different population from that of the bone marrow. And also, ABO subgroup. In patients whose existing ABO antibodies may have been diluted by plasma transfusion or exchange transfusion. Now, for Group 1 ABO discrepancy, how do we resolve this problem? Again, how do we resolve Group 1 ABO discrepancy? Simply, we check the patient's history. Now, if you encounter this problem, you might consider the age of the patient. So the sample might be from a newborn. Remember, newborns would not have ABO antibodies in the serum until the age of 4 to 6 months. Now, if the history naman indicates an elderly individual, or the diagnosis indicates hypogammaglobulinemia or for immunosuppressed patients, then the best way to resolve this discrepancy is to enhance the weak or missing reaction in the serum. Paano po ba ine-enhance yung weak or missing reaction in the serum? This is usually performed by incubating the patient's serum with reagent A1 and B cells at room temperature for 15 minutes. Or pwede rin po by adding 1 or 2 drops more plasma or serum. Now, kapag wala pa ring reaction after centrifugation, the serum cell mixtures can be incubated po at 4 degrees Celsius for 15 minutes. For number 54, which ABO discrepancy is the best explanation for the results shown in the following chart? Okay, so given it reacted strongly po sa forward typing sa anti-A. So, ang blood type po we presume is A, tama? But it reacted, kung mapapansin nyo, it reacted sa A cells also and sa B cells. Okay, naturally, kailangan sa reverse typing po, B cells, positive. But, kung mapapansin nyo, it reacted with A cells po. So, blood type A, that reacted with A cells. Okay, so with anti-A1. Tama? Okay, so ano kayong tamang answer dito? Is it an elderly patient, a subgroup of A, or this may be due to deterioration of reagents ba, or hypogammaglobulinemia? Again, this is subgroup po of A. For number 54, that's letter B po. So, this one naman is yung sa investigation po of weak A subgroups. So, when red cells are made to react with anti-A, N or anti-AB, okay, pag weakly agglutinated po, possibly we can consider A3, AX, or A sub N. Pag walang agglutination, so that means ma-absorb to or ma-elute to ng anti-A. So possibly po this is A sub M, A sub Y, or A sub L. So pag nag-agglutinate, pag weakly na agglutinate siya, tama ba? Mixed field agglutination, pwede nating sabihin this is A3. Pag less than or equal to 10% naman yung red cells show very weak mixed field agglutination, that's A sub N po. And of course, pag weak agglutination with anti-A1B or anti-AB, only, that's A sub X. Next, the following reactions were obtained. So given, okay, the technologist, so first, kung mapapansin ninyo, strongly reacted with all. Sa forward and sa reverse typing, also sa anti-AB. Now remember, the technologist washed the patient cells with saline. Okay, pilot po ng washed with saline, and repeated the forward typing. A saline replacement technique was used with the reverse typing, and the following results were obtained. Okay, so, kahit papaano, nawala yung reaction sa iba, tama? So, sa tingin nyo, anong answer natin dito? The results are consistent with what? Is it letter A, acquired immunodeficiency disease, letter B, Bruton's agammaglobulinemia, letter C, multiple myeloma, or letter D, acquired B antigen? Okay, correct answer po natin is letter C, multiple myeloma. Possibly, Rulu po yun. Okay, Rulu formation po, which can be washed with saline. This one is for the investigation of ABO discrepancy. So, anong gagawin natin? Okay, for ABO discrepancy, when the forward and reverse typing do not match as expected, so ang gagawin natin, we wash the patient's RBCs with saline and repeat testing po. Pag walang discrepancy, okay, we report out the ABO group. But if same po yung unexpected reaction between the forward and reverse typing, we have to consider yung information ng patient sa age, diagnosis, medications, transfusions, or even pregnancy history po. Ano naman, okay, if an error in the specimen collection and identification is suspected, of course, we request a new sample to be drawn from the patient po. So again, kanina, pag na-look up na natin yung information ng patient, based sa age, diagnosis, medications, transfusions, and pregnancy history, we now determine whether the discrepancy in the red cell results, or serum results by observing weakest reactivity po. So for example po, yung problem is sa patient serum. So that's weak reactions po in the reverse grouping. For example po, we have yan, anti-A, anti-B po 4+, A1 cell and B cell, that's 2+. So probably po, that's group AB po with the following possibilities. Maybe a cold-reacting allo-antibody or cold-reacting auto-antibody, also Rulu po. Now, anong resolution dito? So, resolution, we run antibody screen, we run auto-control, or we run, pag Rulu, we run saline replacement po. Now, paano naman pag ang problem is sa red cell? So, this may be weak reactions po in the forward grouping. For example po, kung mapapansin nyo, that's anti-A, 2+, mixed field. Anti-B, no reaction, A1 cell, no reaction, and for B cell, 4+ po. It's strongly reacted. So, this is probably group A with the following possibilities po. So, out-of-group transfusion. For example, group O units po na transfuse sa A patient. Also, sa leukemia or lymphoma, and fetal maternal bleed. So, ano yung resolution natin sa problem na to? We run the DAT. Okay? To determine kung may antibody coating the red cells. And we also run the auto control. Tama? Next, probable group O with the following possibilities naman po. That's, yan naman po pag both serum po and RBC yung problem natin. So, probable group O with the following possibilities: cold autoantibody, cold autoantibody, and cold alloantibody, and possibly acquired antibody. So, resolution for cold autoantibody po, washing the patient cells with warm saline po. Again, washing the patient cells with warm saline and retest.